Dr. Acharya, thank you. That was a wonderful talk and shows your mastery that you had over the years. So the questions, we have several questions, but I'd love to hear their voices. Please come out and ask your questions. I see Dr. Narendra Chaudhary, you have several questions. If you would like to first ask your questions, and anyone else, please raise your hands so that we can take turns and discuss this very important topic.
Hi, sir. Thank you. As amazing as always. My questions are, what is the role of getting venous ammonia that is easier to be sampled than arterial ammonia?
Yeah, you see, normally we normally don't use venous ammonia, particularly in acute liver failure and acute and chronic liver failure. You see, these are diseases where the course is short, and you just heard that circulating ammonia can be converted to glutamine in the muscles. So venous ammonia actually draws the blood predominantly from muscles. So you can underestimate the ammonia value there. Right. But in chronic liver disease, the Spanish and UK study shows that the venous ammonia values are as important to predict liver-related outcome, particularly the ratio.
And what will you do in ALF for high ammonia? Is CRRT
but
better?
In acute liver disease, the absolute value is very important to predict actually cerebral. Well, nobody has compared CRRT and head-to-head plasmapheresis, but plasmapheresis, the European study as well as study from ILBS has shown ammonia actually decreased, and also the British, there are British studies, UK studies which has shown CRRT also decreased ammonia, and this is a retrospective studies, these are not prospective studies, the CRRT, right? But it decreased ammonia, and there had been studies that CRRT after decreasing ammonia, particularly in patients with acute liver failure, can prevent complication and buy time for the liver to regenerate. And particularly in Indian patients whom you see as the viral hepatitis, they're naive patients, unlike in the West where it's a drug-induced predominantly, and many of them can have metabolic diseases there.
Do you recommend checking ammonia in child A, B, or C in absence of HB, sir?
I just showed you multiple studies of stable outpatient cirrhotics, right? Where ammonia value actually has been very well correlated with the 1-year hospitalization, liver-related complication, even survival. But in cirrhotics, you have to measure the ratio as per the documented studies documented in it. These are recent finding. It has right.
Sir, and will anti-ammonia measures like L-ornithine, L-aspartate, rifaximin, they help in management of sarcopenia also? Because ammonia is one of the metabolic factors.
Yeah, but in cirrhotics, there had been randomized control study. At least I know 4 cirrhotics, 4 randomized control study in cirrhosis, particularly those with encephalopathy causing improvement in encephalopathy, because there is a liver reserve left in chronic liver disease where both ornithine and aspartate, you have seen the urea cycle, are actually the feeder for the urea cycle, right? So there is a hepatic reserve, they probably work. But whether they can alter the amino acid homeostasis in muscle and prevent sarcopenia is not known. But remember, removing ammonia is a difficult job, right? Because you see, there is no chelator of ammonia particularly, right? Sodium benzoate binds with ammonia, converting it to hippuric acid and excrete in the urine. There had been only one trial in acute hepatic encephalopathy in chronic liver disease using sodium benzoate, showing its benefit, right? There in L-ornithine phenyl acetate has been shown, and it has been shown by Dr. UCL group, Dr. Jalan's group, both in animal models, that L-ornithine phenyl acetate, right, can bind with glutamine to form phenyl acetyl glutamine, which get excreted into the urine. So removal of glutamine is very important because you see, circulating ammonia will come back to the muscle, form glutamine, and glutamine will go through the circulation to the intestine, will be broken down, it's like Trojan horse. So unless in acute liver disease you remove glutamine, you cannot remove ammonia.
Thank you. Those are very important questions, Dr. Chaudhary. Maybe I'll ask Dr. Anirban, Pragya Anirban. Dr. Anirban, please.
Yeah, thank you, sir, for the wonderful talk. I was just wondering, sir, the impact of concomitant kidney injury, which is very common in CLD patients. So all these studies that you have shown, sir, have they really taken into account this factor, concomitant kidney injury in the genesis of ammonia, sir, in CLD patients?
Yeah. All these studies has overt renal failure, serum creatinine more than 1.5, right? They, in the exclusion criteria, they've included that one of the exclusion criteria. So these are patients of cirrhosis, stable outpatients of cirrhosis, who didn't have overt renal dysfunction. But well, you know, in all patients with chronic liver disease, because of hemodynamic disturbances, the eGFR, if you calculate eGFR, they will be low because of decreased systemic vascular resistance, because of various vasoactive substances which is circulating, particularly endotoxins.
Thank you. Dr. Malayakal from Nashville, Tennessee. Dr. Malayakal, please.
Thank you. That was a wonderful talk. My question is about how exactly should ammonia be measured? Should it be fasting? Should it be, how should the specimen be processed? Because I think the main drawback of ammonia is how the specimen is drawn and how the specimen is processed, so that it becomes very heterogeneous, from study to study. I think the number one thing
that's a very important question and very relevant question, and for that is the reason why most of the earlier study in chronic liver disease has not been able to correlate with the liver related outcome. Now, ammonia is a very volatile substance and its partial pressure is very low. Unless you collect it and immediately within 15 minutes, actually it should be collected, put into the ice in the cold temperature, and within 15 minutes it should be measured. And because if you keep ammonia and measure later on, it will be given a pure underestimation and therefore lack of correlation. That's very, very important. Therefore, ammonia measurement has become very important at bedside. Now, from these studies, it is imperative that ammonia should be done within minutes and at the bedside. So you have to develop a test on chips, right, where you can test the ammonia at the bedside in all patients of liver disease, or in the outpatient and all patients of liver disease. And these are initial studies. Second question, whether it should be done in a fasting or after feeding, is very important again, because we know food itself can influence the ammonia and can cause rises. Suppose somebody has eaten a heavy breakfast with protein, eggs and hams and other substances, and come after 1.5 hours, he's a cirrhotic, and you collect his blood, right? Obviously, his blood ammonia may be higher, which may not actually predict. So it should be a fasting state. In our study, which we conducted in acute liver failure and acute chronic liver failure, in fact, when they were admitted, they were not given anything orally before assessing ammonia at the baseline. And the serial ammonia were measured on the early morning when they are actually fasting, before the feeding was even started. So these 2 points are very important, and therefore ammonia measurement has to be done within minutes and should be done in fasting state.
Thank you. I have one follow-up question. Is there any benefit of simultaneously measuring glutamine in the specimen and seeing if addition of glutamine data to ammonia will be prognosticating?
Well, you see, measuring glutamine may not be very beneficial because glutamine will be continuously changing in the intestine, in the muscles. So it will not be circulating in an absolute manner. It will be also excreted in the kidney if the kidney is functional. But glutamine removal, which is the source of ammonia, obviously will decrease circulating ammonia.
So you don't think that addition of glutamine level of the sample along with ammonia will do any more than ammonia itself?
I don't think, but I don't know unless I measure it.
Thank you.
Thank you. I have a question, Dr. Acharya. Like, if there is a role of measuring the difference in arterial and venous ammonia level, because you're extracting the ammonia is metabolized, and then the level may be different in the arterial and venous. If there is that difference in delta, does it have a role in prognosticating these patients?
You see, it may not have it may actually work in acute liver failure or acute on chronic, but not in chronic liver diseases. You understand? In chronic liver disease, there are various ways of adaptation of ammonia, right? So in chronic liver disease, actually, therefore, the ratio is important, as I pointed out. But in acute diseases, it is arterial ammonia which is very important.
Thank you. I have Dr. Kapoor, Dharmesh Kapoor. Has he left?
Yeah, hi, Sanjay.
Okay.
Good evening,
Yes.
sir. Great talk, as always. But obviously, there is much more to the ammonia story.
Your questions are always very difficult. Yes.
So always a pleasure listening to your talks. They're very, very exhaustive. But I think the ammonia continuum will continue to be unraveled over a period of time. So I will ask something which has always fascinated me. You know, patients who have got uremia, they have elevated ammonia. So we know that the uremic fever is because of ammonia in the breath of a uremic patient. And they can have amounts of ammonia in the breath, which is much higher than even what the cirrhotic patients can have. And when you dialyze these patients, there is a proportion of patients in whom the ammonia actually rises rather than coming down. So I think the story of ammonia is a very difficult to understand story because it is dependent on so many other variables, which in studies we do not talk about. For example, the pH. For example, the acid-base status. For example, whether you have got alkalemia or not, whether you've got hypokalemia or hyperkalemia. So I think these are the things which make the interpretation of an individual value of ammonia so difficult. However, this is a very, very fascinating physiological area, and actually the best studies come from yesteryears, maybe studies done in 50s and 60s, which showed that traditional concept was that because of the photosystemic encephalopathy, and that was the term used in those days, the collateral circulation, that the gut-derived ammonia goes into the systemic circulation and hence produces its effects. And but we all know that the ammonia levels do not correlate with the degree of neurocognitive decline. You can have patients with very high ammonia and still have a normal neurocognition, and vice versa is also true. So even though you've cited a lot of studies, but I still don't think it is actionable. And going from Narendra's question, whether a child ABC cirrhotic patient who has no HE, whether I would want to do ammonia or not, my answer will be no, because it is not actionable. And also the pitfalls that you have suggested of how to measure ammonia. And to that, one could also add the tourniquet bit, which is very, very common in clinical practice. Second thing about why ammonia arterial in acute and not in chronic, because in acute, the muscle mass is still good. And therefore, you believe that quite a lot of ammonia could be mopped up by the muscle. It would not really be relevant in a patient with cirrhosis. And that is why a number of studies, including the sums that you have cited, have shown that whether you use the arterial or you use the venous, it is pretty much the same. Third, to Dr. Ben Meliakal's question, whether the glutamine also adds value, I think it does. And there are at least some old studies where the CSF glutamine has been assessed and found to be better than the ammonia, including the partial pressure of ammonia, to correlate with the neurocognitive function, including the evoked potential studies. So I think there might be some merit there, just as there is in merit in checking
I will
lactate with pyruvate.
answer your question. I will answer your question. Answer. Many of your questions are hypothetical of your own impression. What I saw actually hard data, right? And second thing, what you showed, plasma circulating glutamine level and cerebrospinal glutamine levels are two different ball games altogether.
Yeah, I'm talking of CSF glutamine. I'm not talking of circulating glutamine. Circulating glutamine has got a number of other stories. So this will become a very long drawn thing. And lastly, and most importantly, I still, sir, just let me complete, sir, and then you can.
My point was, you see, what I presented to you, that ammonia story is not finished.
Yeah.
Now, previous as clinician and old studies during also my residency days, until date, like many senior clinicians like you, believe that ammonia measurement in chronic liver disease is useless. It doesn't help you anyway. With ammonia level less than 10 micromoles, you rule out hepatic encephalopathy. You think about other metabolic encephalopathy. That is a standard clinical practice. But however, that may not be true. And there is now certain documentation which demands that this should be studied more thoroughly and more accurately, right? Because if you find a pathogenetic role of this, which is likely to be there, right, one can drive therapy. Otherwise, you are stuck there.
And
that's
action?
The point.
And action?
Sorry?
Action. Supposing you found, and I was for a very long time a very great advocate of the oral glutamine challenge test.
We have to. Now you can predict. Suppose you find it correlation, you can predict. You can stratify patients of liver disease. That we can discuss, Dharmesh, over a long period of time. Stratify.
And sir, lastly, this particular thing, and there are so many studies, including your own study with the UCL group of patients who are very sick, to have elevated ammonia level, which correlates with INR bilirubin. It's just like saying that X correlates with Y, Z correlates Y, and therefore X correlates with Z. So we know that patients, unselected patients of liver disease, of non-liver disease in the ICU, 60 to 70% of them will have elevated ammonia levels. I will repeat that because this is extremely important for the audience. So 60 to 70% of unselected non-liver disease patients in the ICU will have elevated ammonia levels.
No, there are many other patients also has elevated ammonia level. I discussed ammonia level in terms of related liver disease. A severe exercise.
So that's exactly what I'm trying to say, sir.
Cell lysis. Even a cancer chemotherapy can cause rise in ammonia, right? And it has been documented to have hepatic encephalopathy in such patients, right? So ammonia has been seen in non-liver disease related encephalopathy because of sudden rise. That has also been documented.
So that's what I'm saying. So this high acuity patients that you talk of and mention so emphatically that it overall controls the prognosis, that is something that I would still need more evidence to get convinced. So when you have someone who's got a hyperammonemia of say 100 as an ACLF and he does not need a renal replacement therapy, how many of us would still be very keen to institute that? So that is the question. So, when we
depends upon the Dharmesh, you didn't show the dynamicity. Suppose the ACLF had more than 100 micromoles and next day it is 80, next day it is 70. Now he has functional hepatic reserve. He is going to improve. On the other hand, if it persisted, you have a problem. That's what I'm trying. This is another tool in your hand.
Yeah. But it's just that you do not have a very efficient non-invasive ammonia mopper, for want of a better term.
Non-invasive ammonia measurement.
Mopper, something that would mop up ammonia. And that to be the center. So our treatment, treatment will always be to stabilize hemodynamics, take care of infection, take care of nutrition. So our treatment will always be focused on those things, not necessarily ammonia. That's what I'm trying to say.
You don't know what will happen in the future. Yes, at present you are right. Why only present?
Thank you, sir. But a great talk.
Thank you.
This is great discussions. I think we're getting a lot of important points out of it. I think many of us are getting some research ideas out of this discussion. So great, thank you so much. Keep going. And I'd like Dr. Prasun Jalal from Baylor, your insights and questions and thoughts.
Thank you. I really appreciate it. I enjoyed it. It's a great talk, and as always, it's great to hear from the real expert. Now, the Dharmesh and Dr. Acharya should have been debating on this topic. There would have been a whole separate discussion.
It's very difficult to argue with Dharmesh, Prasun. Dharmesh is packed with knowledge, right? He has a sharp and high-class cerebral function. Unlike, I'm an old man, my arterial supply to the brain has decreased.
Sir, we all wish that we were like you at your age. I can bet on it that everyone who's logged on to this program would be wishing for that.
Outstanding, but obviously Dr. Acharya is our role model. So the way I see it, as you outlined very elegantly, that in acute liver failure, the ammonia mostly we worry because of cerebral edema, causing herniation and other problems and worsening of encephalopathy. In ACLF, like picture, is more sepsis, and that's where the ammonia also goes up in that way. So maybe indirect marker or direct marker, I don't know, it's a chicken or egg. So that was actually my question, that do you feel therapeutically we can use any particular agent, whether it's a rifaximin or something else, which will be beneficial, or even modulating gut microbiota, where it can improve the prognosis, either both ACLF or ALF? I mean, obviously, CRRT plasmapheresis has been tried more in the setting of ALF, but not much of in the ACLF setting, unless patient needs it for clinical reason, CRRT. So
I think
how we can
now
use
it is time to do actually trial, because ACLF plasma exchange, there are non-randomized trial.
Right.
Actually. And there are various bioartificial liver support in ACLF that has been used, and there are multiple studies. And indeed, if you see these uncontrolled studies, meta-analysis, it shows that liver-assisted devices, liver support and plasma exchange are the marginal edge, but these are not randomized controlled studies. So it's very difficult to actually clearly opine how to reduce ammonia in such patients. But well, it's time for to develop actually proper randomized clinical trial, taking all variables which affect ammonia as an important variable and stratify them accordingly, and see whether you can intervene with multiple agents which are available, which are so-called can decrease ammonia. But unless we do it, we'll never know it.
Yeah, I agree. But here there are two ways it happens. One is patient comes to the ER physicians automatically, cirrhotic, check ammonia. On the other hand, patient goes to ICU, we have a strict protocol, don't check for ammonia because it's expensive. And so we have to change our notion in the practice. Sanjay, do you have any suggestion how we can utilize this test better in this country?
But gradually, Prasun, gradually it will come in. Don't worry, more and more evidences are accruing. And obviously, in one of those guidelines, where you will people sit, and there will be strong argument, and there will be consensus that, look, we include ammonia, and see prospectively how to improve further. That is the time which is coming. That's why these last 2 years studies I just presented to you to show that, well, there is a candidate. The candidate is measurable. With the candidate, whether it can be treated, and in future, whether it can be assessed to predict its value rather than non-present knowledge.
Thank you. We've been using, Prasun for acute liver failure, routinely using ammonia levels. And of course, so we use early CRRT in patients with ammonia level more than 140. And so the definite prognostic value there. but
No,
not in
main worry
routinely
is
for
the
other
ACLF.
cases. No.
My main worry was the ACLF group.
Yeah. Well, those are great discussions. Thank you. And I love to hear Dr. A.C. Anand, his thought, a lot of work in the area of sarcopenia and relationship with ammonia level. And then Dr. Chaudhary also earlier asked that question, the role of, whether there is a role of any rifaximin, and keeping this ammonia level low will have an impact in the sarcopenia. Of course, I'm not sure there are any studies around, but your thoughts, and maybe in complement with any questions.
I'm a great admirer of Dr. Acharya, and I find it very fascinating when he talks. Just like a professor, he explains everything in great detail. In fact, I have requested him to give this talk as a review article for the Journal of Clinical and Experimental Hepatology. While I do understand that this is coming out as a very new area, new knowledge, I tend to agree with Narendra Chaudhary and Dharmesh on one or two points, that it's not a very practical test. For outpatient chronic liver disease, stable patient, arterial ammonia is very difficult to do. Nobody will allow arterial blood to be drawn. And I have yet to see a hospital which will do this test within 15 minutes of drawing, because you require a very passionate hepatology unit to do that, which is not there in most of the hospitals. So in terms of practicality, there are problems in using this test much more. Your question about use of ammonia lowering strategies in sarcopenia, so far nothing has succeeded. So we can't really talk much about it. Nothing has been able to cure sarcopenia.
Sir, can I just make a quick point, sir? Sorry to interject. Actually, the sarcopenia story is also very good for writing papers. But what we forget is that we are dealing with a human being. And that human being is predisposed to a number of other intercurrent events rather than just, us basing on a muscle building therapy. So one intercurrent infection and whatever you have gained by weeks or months of your rifaximin or probiotics, that is going to crumble down. So that is why all these things are not actionable. I hear so much of this in the meetings also, including transplant meetings. You will not see a single publication which will tell you that this is actionable. It's very good to study functionality, but I don't think it helps you in any way in managing these patients. So it is as if to say that if the muscle mass comes back to normal, all the other problems will also go away, which obviously is not going to happen.
I also said, but the point that Dr. Sanjay Satpathy has made is important, because there's a huge body of research which is linked ammonia to sarcopenia. But whether we can cure sarcopenia by reducing ammonia, that has never been shown.
Thank you.
So those are hundreds of questions will come in, AC, and you cannot stop this argument, because this is a very new and very exciting area, and there are points against and point in favor. But we have to wait and start working on them.
We will start by writing a review article, sir. We request you to submit it to the Journal of Clinical and Experimental Hepatology. That will, I'm sure, generate a lot of interest in people, and more people will get involved in this.
I have one little question. If sarcopenia and ammonia were so well correlated, somebody should do a simple study of patients who have TIPS, because I see many of the patients with TIPS. Now they'll say, oh, that's because ascites, drawing ascites will deplete them of protein. But so the balance is the question ultimately in clinical management. So I don't think there's any study which shows that sarcopenia develops after TIPS.
No, in fact, there are some studies that
doesn't develop after TIPS, but TIPS has been shown to
improve
sarcopenia, muscle wasting. There has been one report, small number of patients, where after TIPS, the sarcopenia was almost cured.
That is what I'm saying. That is what I'm saying. So if the ammonia was so important, then that should not happen.
No, but Benedict, no, that's not true, because with the TIPS, you're not changing the production of ammonia. So how is not going to help? I mean, we are not altering the ammonia level by doing tips.
Of course we are. I mean, the serum ammonia level after tips and before tips, it will always be higher. The baseline level and the peak levels will be higher. And if myostatin is so correlated with ammonia level, the myostatin should be, increased in patients with high ammonia levels, and therefore it should contribute to sarcopenia.
Good
But
point.
we don't know. We don't know the studies. We have to do that. It's nice that it has raised so many questions, so many thoughts, so many things. We have to wait and probably future research.
I think the review article that you are writing, I believe this is a question we should summarize. These are questions that we need to
I think
answer.
what will be helpful in that article is to guide what the future research should project on,
The gaps in the knowledge.
Yes.
Yes.
So if you highlight those area deficiency, like in these discussions today, I think, already we got so many questions. I hope we can answer some of these questions in your review article as well. So we'll learn from that, and maybe we can, direct some research based on that as well.
Okay.
If I can ask Dr. Prasant Bangui, who is, I believe, is a transplant surgeon, and in the role of ammonia, especially how he is utilizing in the ICU setting, Dr. Bangui, your thoughts. I'm pretty sure you have a lot of insights into that you want to give and provide us.
Hi, Dr. Sanjay, and of course, Dr. Acharya. As always, a pleasure to listen to you. Excellent talk, and categorizing it into different scenarios that we deal with every day. I think all of us have been using arterial ammonia in acute liver failure. The acute and chronic liver failure really opens up a new avenue, or probably a new area where insights into this will be very, very helpful. As of now, we are transplanting 30% of our patients whom we are transplanting are ACLF patients. So that's something that has changed just over the last 2 to 3 years. And whatever you say, it may be, post-COVID, patients waiting for a long period of time, acute alcoholic hepatitis, or alcohol on previous NASH. And if we have some more insights into this, whether ammonia plays a role, I'm not very sure, because like all the issues have been raised, I'm not very sure whether ammonia is going to give us that in thing, because as we are talking of ACLF, the most common organ failure other than liver that we have is the kidneys. So in the presence of that renal failure, what's going to be the effect on the arterial ammonia and how we are going to be able to interpret it, I'm sure is something that's open to a lot of studies further. But yes, it would be very interesting, especially if you look at the ACLF scenario, if that is incorporated into already what we are following in terms of organ failure scores. I think that would be something that's going to be very, very interesting. But as of now, deciding on transplant, and we are very big fans of CRRT, I must tell you. We, in acute liver failure patients now, we are doing intraoperative CRRTs, continuing with CRRT, which we start preoperatively. And after we actually have the graft ready and we implant, when we are actually beginning to implant, and we cross-clamp the cava, or we do a partial clamp of the cava, it's only then that we actually disconnect these patients of CRRT, because we found, and our anesthetists are very comfortable with it, the patient, in fact, remains exceedingly hemodynamically stable before we actually put in the graft. One would think exactly the opposite, that, CRRT in the intraoperative period would make them unstable, but it's the other way around. In fact, the real ALFs, they remain stable during the surgery, and we disconnect the CRRT actually off when we actually, put in the new graft. So it has helped us a lot in ALF. In ACLF, ammonia coming up as another factor, I think would be very, very interesting. But those are just a few comments that I would like to share. But thank you again for that excellent lecture.
Comment. I need to ask you from our own understanding. I mean, so you mean you're using CRRT in ALF patient for hemodynamic status maintenance?
No. For
Okay.
hyperammonemia, so I just made a parallel comment that we use it a lot for hyperammonemia. Patients who have hyperammonemia, who have some degree of cerebral edema, we normally do LDLTs in our patient, as you know, in India. And when in the waiting period, to keep the patient, to reduce the cerebral edema to an extent by way of reducing the ammonia levels, we do CRRT.
No,
but
that I agree.
There
But you
was a
mentioned
normal
that
conception. There was a conception that CRRT or any sort of extracorporeal circulation in the intraoperative period would actually tend to make the patient hemodynamically unstable. And that is something that has changed for us over the years, that we realized that those who are really true ALFs with hyperammonemia, with borderline cerebral edema, we tend to now continue using CRRT in them before the new liver comes in and kicks in. This is what I was alluding to.
No, so that's my question. I mean, I agree. For high ammonia, you're doing it, but what's the rationale for using it intra or just before the surgery?
Yeah, so it's because, many a times that small interval between brain swelling going on and progressing to herniation with continuing high ammonia levels and the continuing levels of cerebral edema is very, very difficult to interpret. All of us would have burnt our fingers by transplanting a patient who ultimately never woke up sometime in our, an ALF patient. So that is very, very difficult to define, and especially when the patient is under anesthesia with the pupils which are not reacting, also because of the anesthetic drugs which are given. It's very difficult to interpret the neurological status. And you're always in a rush, you're rushing against time to put in that new liver so that it kicks in an ALF situation. And what you're worried about most is the neurological status. So the reason for continuing with CRRT is those borderline patients who have, cerebral edema, higher levels of ammonia, you're waiting to transplant these patients, and then you're putting in the new liver. Even during that time, if you can maintain a low level of, ammonia and reduce that cerebral edema even further, that would help. That's the rationale.
Yeah.
We would love to see this as your experience as a paper. This is, I hope you've been working on a manuscript on this, I'm sure. What's the number of patients with this? I'm sure it's 300-400 patients already on this.
CRRT with ALF on CRRT and gone ahead? No, definitely not 100, 300, 400, because now we've learned from you guys that there are many who don't need a transplant. So we don't transplant many of them and they get well on their own. And you know that majority of our guys are viral hepatitis. It's either A or E here. A definitely would improve when they have A plus E or they have E. Those are the ones who don't. But I think we have around 35 patients now. Acute liver failure, hyperammonemia, cerebral edema, whom we have taken to theater with, CRRT. And our anesthesiologists are on this, and they probably will come out with a manuscript soon. Yeah.
Well, this is great, and we also learning from your experience. And thank you very much for a wonderful talk, great discussion, and an engaging discussion for everyone joining here. And I think we'll love to, see your experience as a paper, as a manuscript at the JCEH once it comes out. Thank you again, and I look forward to see you everyone in 2 weeks for a very interesting talk that's coming up. We'll send out the emails. Thank you again. Thank you very much.
Thank you. Thank you very much.
Thank you.
Bye.